Good morning and good afternoon to everyone on the line today. Welcome to Access Health International's Confronting the CRM Care Crisis in Asia Pacific webinar. My name is Frances Cassidy McLean, and I will be the moderator for today's webinar. We have a 1-hour session ahead of us, and we will hear from a range of speakers today from across the healthcare system and across the Asia Pacific region about the rapidly escalating cardio-renal metabolic disease crisis in Asia Pacific, what our healthcare systems are currently lacking to achieve truly integrated and patient-centered care, and what coordinated action is needed to address these challenges. A few housekeeping requests before we begin. Please share any questions you have for our speakers using the Q&A function at the bottom of your screen. If you can't see that function, you can click on More or the 3 dots and it should be there. For anyone joining from your mobile phone, you might not see this Q&A function, so you can use the chat box instead. And if you face any technical issues that are not related to your Wi-Fi connection, please use the chat box to privately message technical support. So without further ado, I'd like to introduce you to our first speaker, Dr. Krishna Reddy from Access Health International, who will deliver the keynote speech. Welcome, Dr. Reddy, and over to you, please.
Thanks, Frances. Good morning, everyone. Good morning to my fellow speakers, as well as the participants, ladies and gentlemen. As the webinar title is aware, the problem of cardio-renal metabolic syndemic, that concept of the interrelated complex of diseases accelerating as a syndemic in the Asia-Pacific region, that awareness is gradually improving among the various stakeholders, both policymakers, the public, the health professionals, the providers, the health payers, as well as the public health agencies. The problem is acute. If you understand the 30% of the deaths on account of the CRM in the population, 50% of the premature deaths, 50% of the disabilities, and significant amount of the productivity loss leading to the economic impact. And more importantly, as the population is aging in the region, people living with multimorbidity and multidisability, adding to a significant growing problem in the region. Having identified the problem, the root causes, if I have to outline along different levels, then it becomes easier where the solutions have to be acted upon. If I start with all the P's, that is, one is at a policy formulation and policy implementation level. There has to be a cohesiveness with the understanding of CRM as an interrelated complex diseases when the policies are formulated in the region. In addition, there has to be a coordination between the different departments and also different ministries, because it requires upstream actions by non-health ministries as well as the health departments to have both cohesiveness as well as the coordination at the policy level. At a people level, there is need for lack of awareness, lack of behavior change, lack of participation in the local governance in terms of the decision making at a local level. The third is at the provider level. Given the mixed health systems, which are highly fragmented, highly discoordinated, what it requires is a primary healthcare anchored, integrated and coordinated healthcare systems to ensure continuity of care from promotion to palliation. That's at a provider level. At a professional level, what we see is the expansion into specialization or super specialization has fragmented the healthcare. So there is a need for change in the professional level. Even if somebody is a specialist, I'm a cardiologist, but when I approach my patients, I have to approach first and foremost that I'm a primary care physician. When a patient comes with a problem, Then I have to approach them as a general physician. Then I have to approach them as a specialist physician or a super specialist physician. I think this is another, at a professional level, the change in the concept. These are some of the general issues that underlie the current crisis of CRM. Going to another P level, that is the payer level. While payers are supposed to be ensuring the financial protection and financial coverage, they are also responsible and accountable for the quality of care the beneficiaries are assured by these purchases when they buy from the empaneled hospitals, both private as well as the public hospitals or the public providers. So that is currently lacking in the payer system, that they are accountable for assuring quality and assuring clinical outcomes as well as the patient-reported outcomes. And finally, the public health agencies, so the departments, while the professionals and the providers are responsible for personal health management, the public health departments are responsible for the population health management. So they need to look at what interventions they need to do in terms of the population health management, whether it is health literacy, behavior change communication, health surveillance systems, so the monitoring systems, because these are the insights. They have to continuously inform the rest of the systems and the processes to have an impact on the CRM, the ongoing syndemic. These are kind of a systemic causes and a systemic solutions. I think the panel will be discussing in all these things. And also Rohini's research brings out some of these gaps in the current systems and also possible solutions. But what is specific to the cardiorenal metabolic syndrome is that there has to be a specific awareness that these are not separate diseases, they are interrelated diseases of a single complex. I think that awareness among the policymakers, among the people, among the providers, among the professionals, that awareness is most important. The second is expanding the list of essential drugs and the diagnostics beyond what is currently existing by various countries, including the WHO notification, that the current reality, because these lists were dated, it is almost 2 decades old, unless these lists are expanded to the current reality of the CRM syndemic to include the proven therapies and proven tests at a screening level, at a prevention level, at a therapeutic level, at a rehabilitation level. That means the payer systems to expand the benefit packages to include some of these innovations so that there is an equitable access to innovations. And so these are, and third is in terms of CRM specific competencies in the health workforce, especially at the primary healthcare level and also secondary healthcare level. So these are, I think, a few of the things as an opening context for this interesting panel discussion. I mean, this is just one of the series of webinars, I suppose, that in addition to the systematic research that has given, there will be interesting insights from the various stakeholders, whether it is knowledge partners, whether it is policymakers or the professionals or the patient organizations. So in the rest of this, I think 50 minutes, we will have interesting discussion. At the end of the webinar, I think we hope that we will have good insights, not only from systematic research, but also from the experts who are assembled here in the panel. Thanks for this opportunity to give this context-setting opening address. Over to you, Francis.
Thank you, Dr. Reddy. And now I'd like to introduce you all to Dr. Rohini Omkar Prasad from Access Health International. Dr. Prasad will present an overview of Access Health International's newly published regional report titled Advancing Cardiorenal Metabolic Health in Asia Pacific, Connected Risks, Coordinated Solutions. So Dr. Prasad, over to you, please.
Thank you, Francis. And thank you, Dr. Reddy, for opening today. Good morning, everybody, and thank you for joining us for a very important discussion of this report. So over the next 10 minutes, I will walk you through what the evidence has shown us so far, the state of cardiorenal metabolic health across Asia Pacific, where we have seen the gaps, what these gaps are costing us, and potentially what a coordinated response would look like. So let's get started. To my first slide, please. Thank you. So the assessment that we did covers 5 countries in the region, which is Australia, South Korea, Malaysia, the Philippines, and Thailand. In our methodology, we drew on data from national health surveys, global burden of disease surveys, health financing analysis, and published literature as well. The research was independently led and written by Access Health International Southeast Asia office with funding from Boehringer Ingelheim. So with this report, we aimed for 2 main purposes. One is to be able to give decision makers, policy makers, a real honest account of where health systems currently stand on CRM diseases, and then to offer evidence-based recommendations for a more effective and integrated response. Next slide, please. So as Dr. Reddy also touched upon, CRM diseases, including cardiovascular disease, diabetes, chronic kidney disease, account for more than 30% of all deaths across Asia Pacific, and between 11 to 21% of disability-adjusted life years lost in the region. What the data also shows is that these conditions are increasingly affecting people at younger ages, and they tend to be in combination. So in Australia, more than 38% of adults now live with multiple chronic conditions, a figure that has grown by 33% over the last decade. In South Korea, 51.6% of the population already meets criteria for stage 2 chronic kidney syndrome, meaning that they have established chronic multimorbidity. Closer to home in Malaysia, over 500,000 people live simultaneously with type 2 diabetes, obesity, hypertension, and high cholesterol levels. So the pattern is very consistent across all 5 countries. Disease co-occurrence is the norm. This is not an exception. Current health systems are built largely around single disease management programs, and they are not yet structured to reflect or address this reality. The next slide. So this is one of our report's central concepts, and this has direct implications for policy. CRM conditions are not independent diseases which just happen to co-occur, but they actually share upstream biological, behavioral risk factors. So each condition accelerates the progression or complicates the progression of others. The report specifically describes this as a syndemic, a concept that has important consequences for how we might want to shape care going forward. Clinical data also supports this sort of framing. In Malaysia, more than 80% of adults with type 2 diabetes also have hypertension. 74% also have dyslipidemia or high lipid levels. In Thailand, individuals with multiple chronic conditions were found to have a 43% higher risk of death over a 15-year period. So treating each of these conditions in isolation without addressing the underlying metabolic convergence is a less effective approach. So one component of this syndemic that the report flags as particularly important and under-recognized is MAFLD, or metabolic associated fatty liver disease. This affects 20 to 30% of populations across the APAC region. But most individuals with MAFLD are not dying from liver disease, but from cardiovascular or renal complications, which goes back to supporting the syndemic concept we are talking about. Despite this, MAFLD and its more severe form, MASH or metabolic associated steatohepatitis, are commonly excluded from national chronic disease strategies in almost every country we looked at. And this represents a significant gap that needs attention. Next slide, please. Chronic kidney disease again illustrates the diagnostic challenge that we have looked at the heart of this report. So CKD prevalence exceeds the global average in all the 5 countries we studied, and yet it remains significantly undiagnosed, largely because the condition is asymptomatic in early stages. In Thailand, awareness is low as 1.9%. In the Philippines, 35.9% of patients are already in stages 3 to 5 at the point of diagnosis. This is quite late, and this is 3 times the global rate. In Australia, half of the cases are undiagnosed. A quarter are identified too late for effective early intervention. So late diagnosis has significant downstream consequences. Malaysia expects its dialysis demand to double by 2040. And South Korea recorded the highest global increase in diabetes-related end-stage renal disease between 2010 and 2020. So it's also worth noting that at the 78th World Health Assembly in May 2025, which is just last year, formally integrated CKD in global NCD strategies for the first time. So this is a meaningful step at the global level. The opportunity for us now is to translate that global recognition into consistent national action. Next slide. The economic case for integrated CRM care is also well supported by the data. So direct healthcare costs are substantial across all the 5 countries we have looked at. Australia's direct expenditure exceeded 52.5 billion US dollars, which represented approximately half of disease-related spending. In Philippines, too, chronic kidney disease accounted for over 10 billion US dollars in healthcare spending. In Thailand, productivity losses from CRM diseases, including CVD and diabetes, reached over 900 billion baht in 2019, exceeding direct treatment costs. And as we've been discussing, multimorbidity, or where several of these conditions occurs together, amplifies these costs. So patients who are managing both CKD and type 2 diabetes tend to incur about double the healthcare costs than a patient with a single condition. In Malaysia, the total treatment cost for CVD events in patients with diabetes is approximately 1.3 times that of those without. The implication is straightforward. Investing in earlier detection, integrated management is an urgent priority, but is not only a health priority, it is also a fiscal priority across the region. Cost escalates substantially with disease progression, and they escalate further when conditions are being managed in isolation. Next slide, please. So in our research, we found 6 major challenges across CRM care. The first is late and misdiagnosis, as I've discussed already, particularly for conditions like CKD and MAFLD that are asymptomatic till advanced. The second is delayed treatment initiation, fragmented referral pathways. The third is poor disease control. Australia's hypertension control rate is 34%, which is well below peer countries such as Canada and Germany, which are above 50% each. The fourth challenge is policy fragmentation. Individual disease strategies exist across all the countries that we have looked at for diabetes, for cardiovascular disease, for kidney disease, but none have a unified national CRM framework. So responsibilities are distributed across the sector, but diseases like MASH, obesity might be excluded. The fifth is financing. Most countries operate disease-specific budgets with no mechanism for multimorbidity reimbursement, no bundle payment structures, restrictive reimbursement for innovative diagnostics that support integrated care. There are also persistent resource inequities. Rural, underserved population carry disproportionately high burdens and receive comparatively less investment. In the next slide, we talk about the recommendations. So we developed 7 recommendations that respond to these gaps organized across these 3 areas that you can see. In strategy and policy, we talk about developing a unified national CRM strategy, which is grounded in this framework of syndemic conditions and aligned with with universal healthcare and SDG 3.4, standardized risk-based bundle screening, investing in national awareness campaigns as well. On systems and care delivery, we're talking about redesigning primary care for team-based multidisciplinary management of multimorbid conditions supported by referral pathways. Singapore's chronic disease management, Taiwan's diabetes shared care program are some of the examples that we have looked at and cited at in the report as well that have shown some good results in this area. In financing and equity, earmarking budgets specifically for integrated CRM activities, reforming payment models to incentivize prevention and coordinated care, directing resources to screening, diagnostics in high burden, under-resourced regions, and building out digital infrastructure that is needed to support the coordinated care at population level. And these 7 recommendations are designed as an interconnected package. So progress on financing enables progress on systems. Progress on systems depends on policy frameworks and reinforce one another. Next slide, please. So in conclusion, what we are trying to say is there is a crisis, there's a critical challenge that we are facing, but this is not insurmountable. We do have the tools to address it, and the evidence for action, immediate action, is strong. 3 transitions are what is needed: from reactive management to proactive early detection, from disease-specific plans to integrated multimorbidity strategies, and from fragmented services to coordinated whole-of-life, person-centered systems designed to sustain health. So none of these strategies need to be started from scratch. They require redirecting existing frameworks, aligning the institutions and the policies to support this. Last slide, please. So in closing, our full report, including country-level data, recommendations, etc., is available on our website, and you can scan the QR code to access the reports as well. We hope that this is going to be a useful resource for the discussion ahead. Thank you all for your time. I look forward to the conversation.
Thank you very much, Dr. Prasad. Next up, I'd like to introduce you Manveer Victor, who is the co-founder of Vital Signs Asia. Manveer will present about the real-life burden of CRM diseases as a CRM patient advocacy leader in our region. Welcome, Manveer, and over to you, please.
Thank you so much, Francis. Good morning, good afternoon to everyone who's on this webinar right now. Thank you so much to Access Health for having us on. I want to first agree a lot with what Dr. Reddy has said and Dr. Rohini as well in the presentation. It's frightening, isn't it? It's absolutely frightening. And I'm one of those patients that has gone through the system, and I still am a patient in the system. So let me give you a brief look at what happened. Was in the year 2001, I was diagnosed with end-stage renal failure. This came about because the cases of screening or the occurrence of screening was very rare then. And when I was eventually diagnosed with end-stage renal failure, it was by a physician who sent me along to a nephrologist. And from the nephrologist is when I started learning about my condition, which could have been prevented very much earlier had there been a proper screening program and dissemination of that information to as many people in the public as possible. Now, as I started on this journey of being on dialysis, I was on dialysis for 10 years, from 2002 right up to 2012. Obviously, when I was on dialysis, it was absolutely difficult. I was only being treated by a nephrologist. I was not aware of the other illnesses that could occur or other conditions that could occur to me from being on dialysis. As a result of that, if I'm not mistaken, about 85% of people who are on dialysis develop a heart issue. I am one of that 85%. I have got a systemic heart disease right now. I have heart failure. I'm from that, but I am being taken care of for that. I do not have, I now have dialysis. Now have diabetes because of the medication that I am taking. So I'm being taken care of the doctors as well. So currently I have had my transplant in 2012. I'm pretty well, as you can see. But obviously, I now have ICD implanted into my heart because of my heart failure. I do exercise I very, very regularly, in fact, and I still have diabetes because of the medications that I am on. So it has cost me that in terms of time. Now, let me go back to what Dr. Rohini was presenting that just now about the 11 to 21% DALY, right? Daily life adjusted years. Now, very simply, I'm going to put this to you. Those 10 years that I was on dialysis meant that I had to resign from my job. I had to be on government welfare systems, right? I had to fend for myself. And I did a very rough calculation, and I either directly or indirectly lost about 1.25 million US dollars over those 10 years. About 250,000 to 300,000 US dollars went on my dialysis treatment, on my medications, on my jabs that I had to get just to continue to be ill. Right? And post-transplant, obviously, I'm on a different gamut of medications. I've had my ICD implanted and all these things, but I'm able to work. Now, just to put it in perspective to you, that 1.25 million US dollars that I lost in that 10 years, I will never be able to recover that, because it means out-of-pocket expenses. It means the loss of earnings, the loss of savings, the fact that I had to sell my house, all these things. I will never, ever recover from that. And, just to give you a face to all the data that Dr. Rohini brilliantly presented there, is the fact that I am one patient. And if you're looking at the sheer numbers of patients that they have been sharing already, you can see that the cumulative effect is that billion-dollar loss that every country is going to incur. So this, from a finance perspective, is where we need to look at it and understand that we really need to get together and break down these silos. I am all for CRM, multidisciplinary look at a patient, because we are able to stave that off early in the diagnosis and save that patient and the country, that nation, that welfare system, that healthcare system, all the expenses that can be held there. So looking at that, and I have to note, Dr. Reddy was talking about the silos inside it. So now I'm still in the system, but I have to see 3 or 4 different doctors. And in Malaysia, unfortunately, we don't have a digitalized system. So I am the carrier of my data to all my doctors. So once I've seen my nephrologist and I've done a test with him, I have all my data, which is kept on my phone. So when I see my cardiologist in a different hospital, I have to share with him that data, plus the medication that my nephrologist has given me, and vice versa. So this constant talking has been done, and it's propagated by us, the patients, that we are sharing, so that we are able to get that better care. Now, this is me, one person. There are thousands, as Dr. Rohini has shared, and maybe hundreds of thousands in your own country that are falling by the wayside. So this is actually a lost opportunity to a lot of healthcare to be able to consolidate and to take care of the person, not only the patient, but the person who needs that care as quickly as possible so that they do not get worse. The loss of my income, like I said earlier, I will never, ever recover from that. But I am just glad to be alive. But that's just me, right? And we are doing whatever we can to help this conversation so that healthcare policymakers are able to understand that the data points that we are sharing has a face to it, has a life to it, and has an effect to it that is far more present than they can even think of. We are dealing, obviously, with my organization, we're dealing a lot with policymakers, and we try to make sure that the patient's story, the person's story, the family, the caregivers is very, very important, because that is the lifeblood of any nation. And as we look at healthcare and the 2 words of health and care that are fused together, we understand, obviously, that one goes in hand with the other. So that's very important for us as patients to be speaking to you all here today, and as well as policymakers, to ensure that this is communicated to them, because the lives that are affected actually affect the productivity, the financial status of each one of our countries, not to forget, obviously, the lives that are affected by it. I thank you, and I look forward to the panel session a little bit later.
Thank you very much, Manveer. Now, we are moving on to the panel discussion portion of our webinar today, which will explore what action is needed to progress CRM care in the Asia-Pacific region. Let's welcome our distinguished panel. Dr. Rabindra Abeyasinghe, WHO representative to Malaysia, Brunei Darussalam, and Singapore from the World Health Organization. Manveer Victor, co-founder of Vital Signs Asia, welcome back. Chris Forbes, CEO of Kidney Health Australia. Dr. Donna Francesca De Leon, Board of Trustee and Committee Chair on Advocacy from the Philippine Society of Nephrology. And last but not least, Dr. Krishna Reddy from Access Health International. Welcome back. So let's get started with the panel discussion today, kicking off with our first question. And this one is going to be for Dr. Abeyasinghe and Dr. Reddy. So Access Health International's report emphasizes that CRM diseases are not isolated silos, but rather an interconnected syndemic, as we've been discussing so far today. So considering this, how can Asia-Pacific economies move beyond currently fragmented and disease-specific approaches to develop unified national strategies that integrate CRM care and also align with broader health goals like universal health coverage and sustainable development goals? Dr. Reddy or Dr. Abeyasinghe, perhaps you'd like to start with this question.
Yeah, I think Dr. Ravindra can go ahead.
Okay, thank you. Thank you so much for the question, and thank you for inviting me to join this important discussion. I represent the World Health Organization. I want to reiterate that we are not the World Medical Organization. The difference is that we advocate for health, but the syndemic that our countries in Asia Pacific are currently experiencing creates a situation where we also need to extend and improve the coverage for people affected by those diseases. And that is posing a socioeconomic challenge to the health systems on how do we do that. And so it begs the question of an essential rethink on how the service delivery is provided in response to the existing syndemic. But beyond that, we also need to step back as physicians and look at how do we advocate to stem the flow of patients? How do we make a change in reducing the numbers of people who will be affected in the future? Because as you mentioned already, in countries, the systems are under immense pressure. And so it is important, it's vital that we focus on this two-pronged approach that we need to have. It's all about expanding access to care and providing better care to the people who are already affected. But at the same time, finding the resources and the approach that is necessary to ensure there is a change in the inflow of potential patients. And that is by creating a shared awareness among people on the social determinants of health and the commercial determinants of health that need intervention at an upstream level, at a very personal and community level. If we can ensure that, we are going to have some hope that we can find a solution around this. But that does not take away from the fact that we still need to improve the way we address the existing challenge that the near future is going to increase and multiply. And so a syndemic approach, a new approach to managing the patients is vitally important. WHO has recommended some new therapeutics. We are advocating for countries to adapt them. Of course, there are issues about the pricing, which need to be addressed. That will help in reducing the challenge of obesity and diabetes and potentially reduce the opportunities of complications arising in those affected patients. If we can do that at scale, there will be some hope that we could start flattening the curve. I'm not saying we can turn it down, but at least to start flattening the curve for a start, while we intervene upstream as a community to advocate for a change in lifestyle and a shared responsibility of the population to adopt better health practices that will help in addressing the risk factors and the challenges that result in the syndemic that we are experiencing. Over to you, Dr. Reddy.
Just carrying forward what Ravindra said, I mean, my perspective will be as a health systems researcher, a knowledge partner, and implementation partner. Whatever the SDGs that were enumerated and all the member nations have agreed to, this is 2050. That means the research precedes by another 3-4 years. But a lot has changed in the last 15 years. So some of the targets which are already laid down as a part of HDG or USC, they needed actually a further refinement and adoption to the region as well as the national or the subnational context. I think that is missing because everybody is just still targeting what was laid down in 2015, but the concepts have changed, the understanding has changed. And again, each country is in a different maturity of evolution of their health systems or their socio-economic systems. WHO as a knowledge partner to the government, because it's an official formal knowledge partner to the government, has to translate the global recommendations to the regional recommendations, to the national and the subnational recommendations. I think that's one imperative because WHO is best positioned to bring about this. When you look at the USC indicators to measure where the country is, none of these diseases that we are talking of actually figure in the access to essential services, access to essential diagnostics, access to essential therapies. That means there is a need for continuous updation, maybe every 3 years or every 5 years, updation to these lists by the country concerned or the region concerned, so that the people are not actually waiting for these policy interventions when the drugs are already available, when the diagnostics are already available. So that is, I think, the second element comment related to this. The third is my own assessment is there is enough policy awareness, there is enough policy attention. Every country has a national action plan, either NCDs as a whole or diseases as individuals. But what many countries lack is effective implementation, inability to effectively implement, either because financial resources are not sufficient or they are not efficiently deployed, or health workforce is not sufficient in numbers or sufficient in competencies or sufficient in distribution, or we are not able to leverage the power of the emerging molecular and digital technologies to bridge some of the unbridgeable gaps in the systems. So I think the ongoing discussions will bring out there are a lot of proven strategies, proven interventions in different countries, maybe in silos, but across the countries, we can learn from each other that there are applicable, proven solutions, whether it is a policy level, whether it is a community level, whether it is a provider level or workforce level or the payer level. So I think there are different interventions. What we need is just combining all these interventions and then putting them in iterative intervention mode, because we cannot re-engineer everything. Health systems are so complex. It has to be done in a continuous performance improvement mode using the systems approach. We don't have robust surveillance systems. We don't have robust monitoring systems in the public health agencies. Unless we have these robust systems, we don't know whether our interventions policies are working or not. So I think these are my system level assessment, what actually lacks. And there are many countries, I think, doing excellent work, but in isolated interventions. So I think I leave it here, talking more from a systems thinking, how the CRM syndemic can be tackled.
Thank you very much both for your assessment and insights on that point. So moving on to our second question, and this one is for Chris and Manveer. So one of the most striking findings in the report is the high rate of underdiagnosis and late-stage presentation of CRM conditions, particularly for the silent diseases that we touched on today, like chronic kidney disease. So the question to you is, what are the key steps needed to introduce standardized risk-based screening for CRM conditions across the Asia-Pacific region? And how can we overcome barriers to earlier diagnosis?
So look, I'll start, and thanks to Manveer for bravely sharing his story. Can you imagine, this week I've just learned of 5-year-old First Nations children who have diabetes and starting dialysis at 12 years of age. So it's completely unacceptable. We have the highest recorded rates of treated kidney failure in the world here in Alice Springs in Australia. And so we have to intervene. I'm continually frustrated that, when I go to the doctor, I don't want to be treated as a disease. I want to be treated as a patient. And I want that doctor to be able to spend the time with me, to ask me the questions, for me to be able to tell my story. But they tell us they're continually frustrated as well because they don't have time. There's 5 people in the waiting room. They're not funded to do a chronic disease assessment, etc. And they also lack the knowledge. Most of the doctors have been graduated since the new drugs have come out onto the market, etc. So we have a responsibility to help our health professionals. So, in the case of chronic kidney disease, it's not difficult. We know where it lives. It lives with diabetes and hypertension and cardiovascular disease. We have the tests already, blood and urine and blood pressure. We have the new medications available to patients. They're just not being used and it's not being detected. And here in Australia, we've got 2.5 million Australians who have early markers of chronic kidney disease yet remain undiagnosed. So we need to do better. We know that the vast majority of people with risk factors for kidney disease have not had a test. And if they have, it's generally blood and not urine. So it's not insurmountable. We can actually do it. But as you said, there's a number of levers we have to pull. My job is to inspire health professionals to do that. And that's why we have a bold aspiration to end dialysis by 2050, because we want most people don't make it to kidney failure. They die. They die of a cardiovascular event. So we need to intervene earlier. Kidney and cardiovascular and metabolic, it starts early, it's progressive. There are windows where we can intervene, and that's what we need to do.
Thanks, Chris. I just want to jump in that obviously what Dr. Krishna was talking about just now was the data. We need that data. It is absolutely essential. And when I say we, I look at myself as part of healthcare already, being a patient in this journey for the past 25 years. And, engaging with policymakers, with doctors, with hospitals. So we need that data to be able to pinpoint whether the interventions are working. Absolutely necessary, because we know what works and what fails. And then we know how to improve upon that, which is absolutely important. And also, if you look to getting that public awareness that Chris is talking about, to the doctors and to public itself, we need to be reaching out in different ways. And I sympathize with healthcare, because in a world of 8.4 billion people, there are about 65 million healthcare professionals in the world. I bet there are probably more waiters. And that is how sad the situation is, because that's 65 million healthcare professionals are supposed to take care of 100% of the people in the world. It is insurmountable. It needs the help of patient advocacy groups. It needs the help of people on the fringes of healthcare. And we really need to look at the way the system is developed. Social determinants of health is very, very important. There are some countries and some cities that have done really, really well with it. We've got to take a leaf out of that and localize it. And so the data is important, and how we reach people is absolutely important. If a patient already comes to the hospital to get diagnosed, we have failed. We have to understand that we have failed if the person turns up on the hospital door and gets diagnosed there with end-stage renal diabetes or any of these things, then we have failed. It has got to be a hard stop to this. We've got to go outside the hospital. We've got to reach people. And that is the only way we can do what Dr. Rabindra was saying, is maybe flatten that curve a little bit. Thank you.
Thank you very much both for your insights on that important point. So we're now going to move on to our third question. This is for Dr. De Leon. As the report and today's discussions have highlighted, fragmented services and poor coordination within primary care are significant barriers to effective CRM management. So the question is, how can primary care be redesigned to better manage multimorbidity through team-based models? And what role do referral systems and patient empowerment play in ensuring continuity of care?
So good morning, everyone. So living in a country that's fragmented geographically, we have 7,107 islands, and we often see like diabetes patients who learn of kidney disease when they need dialysis already. And we also see patients going from one clinic to another who's hypertensive, and by that time they have heart failure. So again, the primary care redesign is very much aligned with us, which is very imperative in strengthening primary health care for team-based, patient-centered management and complex CRM multimorbidity approach, which means that patients or doctors, cardiologists, endocrinologists, even nephrologists shouldn't work in silos. So they need a team-based approach when dealing with these types of patients in order to prevent catastrophic disease such as ESRD. So we also have, aside from being geographically challenged, I think we also need to close the gaps in the patient pathway by addressing delay in the treatment initiation. This means that being separated by islands doesn't mean that we can't bridge this gap, because we could extend these primary health care clinics in the barangay level, and then engage the area in terms of a very robust referral system, which we also lack in terms of primary care. That's why patients don't get treated and initiated with the best treatment possible, because of this fragmented referral system and loss of follow-up, especially among patients who don't really get the idea of what this holistic approach means in terms of their disease management. So since we are also very much challenged in terms of funding, I guess we're moving into public-private partnership. Some of the centers with the new initiation of the government in terms of funding have utilized some private hospitals also in terms of delivery of these diagnostics that are not available in the local hospitals that we have. So they've partnered with certain private hospitals in terms of providing at least the basic that patients need in order to prevent CKD progression and even heart failure progression. And they also engage much of the physicians, which are also not present at the local level. So these are the things or the initiatives that the government have done in order to really address the growing gap in terms of delivering a holistic approach in terms of care among these patients and not working only in silos. So I guess that's one of the things that we can share about the Philippines.
Thank you very much, Dr. De Leon. So we're going to move on to our final question of today's panel discussion. And this one is for all of our panelists before we take a couple of questions that we've had from our audience. So panelists, if you can summarize the one key takeaway or call to action that you think is of utmost importance to address the CRM burden in Asia Pacific, what would that be? And Chris, let's start with you, please.
Look, today I'm here in our national capital meeting with my compatriots from Heart Foundation and Diabetes. So it's time we started to work together, and there's a willingness. I need political will to help drive that through. And I think the first thing that we could do in primary care is to establish a kidney cardio metabolic health check that's funded by government, so that when a patient comes in, they are screened for their diabetes, their heart, a risk test for their kidney, etc. And from there, getting it early, it can then absolutely transform the pathway of healthcare that individual is on, because early intervention is the best outcome for patients. It's the best outcome for our healthcare system. It stops our hospitals from clogging up. It helps our economy. But I come back to it, the most important outcome is patients, families and carers. They don't reach into those last terrible end stages of disease. Let's start there.
Thank you, Chris. Dr. De Leon, back to you, please, for your one key takeaway or call to action.
I think bridging the gap in terms of how this CRM could be strengthened should start from the primary care, because that's the beginning where patients would be taken care of at the primary care. And it is good to hear that our government have started this with providing the YAKAP, or the Yaman ng Kalusugan program, which starts with the primary care by providing them with avenues for reimbursement for basic laboratories and also free consultations at the primary care level. I think that's one major gap that we didn't have before. That's why patients would go to us with the late stages of the disease. And I think this is one good thing for low-income countries to start with the CRM model.
Thank you, Dr. De Leon. Manveer, over to you, please, for your one key takeaway or action.
I think the fact that we've got to break down the silos is, from a human perspective, important. From a financial perspective for the nation, absolutely key. And if you look at health as a human right, the ability of the person to earn the money, to be able to go and be educated, to be able to contribute to every country is critical. It is critical. Any country is only as strong as its weakest link, and that is the patient. And if we can help that patient get back on their feet faster, or even not fall ill, that will be the key to keeping us in a better world.
Thank you, Manveer. And Dr. Abhay Singh, over to you, please, for your one key takeaway or call to action.
So we have recommended advancing universal healthcare built on integrated primary healthcare, which is people-centered. This is what is lacking. This will be the backbone where all the other changes can be built upon. So it is a difficult journey, but it needs to be accomplished as quickly as possible as a part of the solution for this emerging syndemic.
Thank you, Dr. Abhay Singh. And finally, Dr. Reddy, your one key takeaway or call to action, please.
Yeah, if I had to summarize in 2 words, what we need is better coordination at different levels, better collaboration, and better integration, because today the information technology enables you to integrate. That means if you have an interoperable health record system, a portable record system, and a handover system from one health worker to other health worker, These are simple interventions which can actually integrate both, as I mentioned, horizontally and vertically, and achieve the coordination, because people have access to these services. They have financial protection. Despite that, only 20% are controlled, outcomes continue to be poor. The root cause is lack of coordination, because the patient is forced to navigate a complex, fragmented healthcare delivery system. You have modern medicine, traditional medicine, you have private care, public care, you have primary healthcare, secondary healthcare, tertiary healthcare. So what it requires is this integration and coordination. I think this is my root cause analysis that might a system solution to the CRM syndemic. The second is the community interventions. This is health system level interventions. The community level interventions are as equally powerful as system level interventions, be it health literacy, be it behavior change communication, be it participatory local governance, or be it self-care. I mean, capacity building through a self-care, because every family member is a caretaker. And today's technology enables them to have a self-care. I think these are the two, at system level, at a community level.
Thank you very much, Dr. Reddy. So we have time for maybe one quick question from the audience today. And it's coming in the Q&A, and it is that the audience member agrees with integrated intervention. However, how do we start this? And is there a lead agency who could help us or support us in this journey? Any of the panelists want to take on this question from the audience?
Francis, if I may, we have given the strategic and the policy directions. Of course, every country has to decide on its own, based on its own specificities, how that system needs to be built. But from a WHO perspective, we've given the recommendations. We have created the technical guidance. They need to be adapted to national contexts and national systems in the implementation.
Yeah, Francis, I think we are piloting as an implementation partner to at least 3 state governments, large state governments, and both as a payer-driven integration, a provider-driven integration, and a public healthcare-driven integration and coordination. Maybe if the time permits in the future webinars, we can share some of insights from not only these pilots, they are being scaled up across the states. So I think in the future we can discuss on this, actual translating what WHO has given strategies. We see a major challenge in their implementation, because strategies are well designed. I think the WHO has excellently designed the strategies and the policies. What we lack is the effective integration and implementation.
Thank you, Dr. Reddy. Thank you both for your insights on that. And we may just take one very quick, one more question from the audience. Perhaps Dr. De Leon, Chris and Manveer, you might want to share your thoughts on this. So the question is, what does good interdisciplinary care actually realistically look like in practice for patients?
Okay. At least for the Philippines, because I told you that we really lack this, we should be engaging the primary health care physicians, because the specialists, the patients have ready access to the specialist, but then majority of the patients who doesn't have the funds to go to the specialist would go to the primary care physicians. And I think one of the major gaps is that this primary health care physicians, or primary health care in particular, is the one neglected. That's why we get patients without this direction going towards a multidisciplinary care, starting from the primary care physicians, is very much lacking. It's a very big gap in the Philippines. Wherein, if this could be bridged closer, I think that's one major step towards preventing the exacerbation of the diseases, and patients can get better care out of this multidisciplinary approach if they are able to learn this earliest possible time, starting with the primary care.
I totally agree with Dr. De Leon, because in Malaysia, where our population is 34 million, We have got 14,000 primary care clinics all around, and it is underutilized. We very gladly boast of the fact that any citizen in the country, or rather 95% of the citizens in the country, have access to a clinic within 5 kilometers of where they live. So they can get that help. Unfortunately, they are not trained. They are not trained. They're the low-hanging fruit. They are there, but they are not trained to take care of these patients. So that is something that we really need to sort out as quickly as possible. Thank you.
And Francis, I think just to finish, there's also an opportunity through pharmacies. You know, you go to your pharmacy and you get your diabetes tablets, then have the pharmacy tell you about your kidneys. Using software that can give an alarm to a doctor, say, hey, based on everything they have in front of me, you need to be telling this to the patient and getting these tests done. And AI will certainly do that. And here in Australia, not just the GP, but the practice nurses. Nurses can offer so much of doing the groundwork of testing, etc., so that the GP has more time with the patient to discuss their chronic disease. So there's opportunities as well in innovation.
Thank you all for your thoughts on that question. So unfortunately, we're at time now. So we are going to close the panel discussion and the webinar. So thank you to all of our speakers and panelists for the very insightful and fruitful discussion that we've had today on this highly relevant and important topic in our region. And to our audience, thank you for your attendance and interest and engagement in this topic. Today's webinar is just the start, a first step for us to spearhead multidisciplinary discussions around a truly coordinated response and political commitment to holistic CRM care in our region. So let's continue to learn from each other and work towards advancing CRM care in the Asia-Pacific region. Thank you again for joining us today, and good afternoon.